So yeah, good afternoon, everybody. Thank you so much for joining today's session. My name's Stacey Thompson. I'm one of the programme managers at Redmoor Health, joined by my colleague Claire Temple, who is Digital and Transformation Programme Lead. And we also have delighted to be joined by 3 speakers this afternoon who will contribute during the session. So we'll be taking you through the presentation this afternoon. Thanks, Claire.
Fab. So first of all, just a little bit of housekeeping. So please be aware that your videos and your microphones have been turned off just while we go through the presentations. But if you do have any questions whilst we go through, please can you pop them in the Q&A section and we will pick them up as we go through or at the end when we get a chance to ask some questions of the panel. We are recording the session today, so that has already started. And if you haven't registered for this session directly through one of the registration links that we sent out, please can you just pop your email address and job title in the chat so that you can get sent the resources after the session. Also, if you're not a D&T network member, we'll give you information on how to access that. And then lastly, at the end of today's session, we will be asking you to provide us with some feedback on how the session has gone today. So if you could hang on to do that for us, that would be much appreciated. So we're here to help you today to see where there might be some opportunities. So we're not income maximisation specialists, but we do have slightly more time than you do to research, find examples and to understand which digital tools can support and help you via the network, and share experiences and ideas and signpost you to specialists who can help. So the plan for today's session is we've got a fair bit to fit in, but hopefully we'll have plenty of time for questions at the end. So we're going to look at some optimization areas. So maximizing the global sum. It's your registered list. It's the accurate registered list for you, and what you're doing to attract new patients and making registration easy for them. So Jay, one of our speakers today from SmartLife, has done some work on increasing list size, and he will share that with you a little later. We're going to look at QOF, understanding the business rule changes and the enhanced services. Have you worked out the cost of delivery, and have you considered some of the delivery of the elements across the PCN rather than doing it separately in each practice? Additional things that we'll be looking at, things like premises, your private things that you can charge for, the training, research and dispensing. We'll be talking through them. And we'll be looking at some operational efficiencies. So within your workforce, with your practice and your PCN, whether it be technology or digital or business intelligence, and a little bit about compliance and risk and CQC. So throughout the session today, we are joined by 3 speakers who are going to go into more detail on some of these areas with some real life examples and some of the platforms that can help you. And finally, we'll share offers of support and additional resources and the chance for you to think about your next steps. So this is our D&T network. We now have over 1,000 members, and as you can see there, it is our first birthday. Happy birthday to the D&T network. It includes lots of product suppliers, subject matter experts, and people like you who live with this and work with it and can help each other. If you're not already a member of the D&T network, you can scan the QR code now, but you'll automatically be sent an invitation after this session so that you can join the Digital and Transformation Network. So as I say, it came to life last September, October, with an aim to connect everyone across healthcare that is interested or involved in digital and transformation. And there is a wealth of information and connections on there for you to look at. So all of the templates and the resources that we share with you today will be available through the D&T network in the workflows and efficiencies category. There are also several supplier and support groups on WhatsApp and LinkedIn that you may decide to join. There's lots of them out there. So Some of the resources that you might find helpful from Redmoor Health are also available, but they are in the D&T hub, such as the new income maximisation toolkit. If you don't have access to the digital and transformation hub, we are offering a £99 per month support offer, and that includes, along with monthly call with one of our team to support your practice, monthly webinars, targeted digital guidance, a monthly toolkit like this income maximisation one, access to our digital maturity index, and ad hoc email support. So if you'd like to find out more information about this, please pop something in the chat, or you can email support@redmoorhealth.co.uk, which will pop in as well. So we're just going to first start by asking you a couple of questions. So we did already send out a few emails to some of you beforehand. And this is the answers we got. So what are your main income challenges? So we know some of you are in new PCN roles and are trying to balance supporting all of that stuff that's going on in the PCN. And there's very experienced managers who are also on the call today. But we need to find out what's your main income challenges. So I need to see the answers to them, which I can't at the moment. There we go. So we've got here pretty much the same as what's on the slide as well. So staff, workforce, income streams, list size. So there's lots and lots of different things that you'd be struggling with and looking for support with. So that's great. And just one more question. So do the PCN and its practices have a common understanding of how to maximise income collectively? So is there an agreement to maximise income for the whole, for both PCN and practices? So not as separate organisations, or is there a situation where you're competing with each other? Is there any source of tension? Can anyone offer suggestions to help with that if there is? But benchmarking across neighbourhoods or PCNs should be more productive. Data is only helpful if the people in the room are engaged to learn and appreciate peer support, and they don't feel threatened by benchmarking, but it's generally great to work across a PCN. I can see the answers that are coming through. So there is there's only 9% that currently have a common understanding across the PCNs to do it collectively. So that is something interesting that we can maybe give you a little bit more information about today. So we're going to start by looking at QOF. So for 2025-26, 32 indicators that were worth 212 points have been retired, and 71 of these invested into the global sum to increase the service fee for childhood vaccination. So that's gone from £10.06 to £12.06, and the locum reimbursement rate has also increased. And the remaining indicators are now targeted at CVD prevention, and they're spread across 9 main prevention indicators, and the upper achievement levels for all of those indicators have been raised, so they're offering a really good opportunity to earn points this year. So Kavita from Oberoi will be speaking to you in a moment about the use of the QOF calculator to help see where the trends are, as well as the opportunities. And whilst many practices achieve high QOF points, there's still a lot of variation within PCNs. So as you can see, so 68% of practices achieved over 95% of points. But again, there are regional differences. So for example, in 24-25, the London region show lower average achievement, and the rural regions generally outperform. So the new neighbourhood contracts may challenge rural general practice significantly. So this is something that we need to take into consideration. and population demographics, they affect achievement rates. So we've seen some areas with multi-ethnic communities finding it a real challenge to hit VAX&IMS targets. We are providing support through our social media managed service for this to improve communications into different languages and some imagery to help with the uptake of this. Again, if you're interested in learning more about this, pop a note in the chat or email the team and we'll be able to give you a little bit more about that. But even if you are maximising your QOF income and achieving all of your points, there may still be stuff to consider today about the delivery. That could mean that your expenditure is reduced. So your biggest cost will be staff time. So using digital solutions to support admin and clinical teams or working across your PCN might decrease some of your costs. And while this doesn't increase your income, it can help to maximise your profit. And here are some of the income opportunities for QOF. So we've done some analysis based on the QOF achievement patterns from 2024-25 to highlight just the potential additional income that could be gained. So you can see there that the bottom 25% of practices could be getting an extra nearly £30,000 annually to top them up versus the middle performing practices, which again is still £11,000. That's a lot when you think about it. But yeah, regional variation suggests system level factors and peer learning opportunities between regions. So I'm going to pass over now to Kavita from Oberoi. Thank you very much for joining us today. And I will let you share your screen.
Thank you very much. I'm just going to present our tool that we've just been QOF tool to help practices that we've been developing over the last 6 months. We've actually been working with the NHS for 25 years now, so I'm quite excited to show you this tool. Okay, so everybody see my screen? So for those who actually get access to our tool, and I'll send some details later, when you go into it, once you sort of log on, you'll be able to see at a glance how many weeks you have remaining and the income you've achieved so far. When you first go in, you'll be able to download some searches that we've created that feed the tool. There's a guide on here as well for System 1 and EMIS, and there's also a video. So once you download your searches, you run them and you upload the search results, and you can do that on a weekly basis because data is changing weekly, and then you get the magic. So imagine this will come out when you run those searches. So this will give you a very, very clear action plan. If you hover over any of these, you'll see the various domain indicators. Now what this shows is how many patients there are still to recall for this particular indicator, and the additional income. It's been sorted by the least number of patients with the maximum financial value. So we can see here these 21 patients, the additional income available is £6,000. What we've also added are some appointment options and durations. So depending on the indicator, you can look across and then you can see, well, actually, we're going to need 21 extra appointments. If we did 10 minutes, how much time we will need, and it will help you with resource planning. So this is one of the key tables, and that's how it works all the way down. And if you haven't got enough resource from the end of the QOF year, again, we may be able to support with clinical support, but this really maps out your action plan. And the idea is that you upload your new data weekly because it's changing, or monthly, and you've got this for presentations. So that's one view. Then I'm going to show you another view. So this next view helps with validation. It's your validation plan. So it shows you which registers are lower than England. So in this practice, you can see which of the practices have got which registers are lower than England prevalence, and how many patients are required to achieve that England prevalence, and the value of each patient that's added to the register. The table below shows those registers that are above the England average and the value of adding an extra patient. And if you wanted to see the data in a different view, just to see it by the different domains, because you may be talking to different teams, you can have a look at this view as well. It just puts it all together. And as you populate and you action those patients for the action plan, they'll all start falling into here. So these are all the ones that have been done. And if you did want to improve quality further, you can see the numbers of patients that still need to be actioned. Now, one question may be, where do we find the patients? Where do we find these 21 patients? So we will provide you with the searches that sit on your system, and they'll all be very clearly labelled. So you can just click into the search and find those 21 patients. I will put into the chat a link to this page and the demo page, so you can have a look at it in a bit more detail. And as we've got a few minutes at the moment, I'm also going to share with you a presentation from a practice manager who's been using this tool and how they introduced it into their practice. So this is Will Moyle from Topsham Surgery in Devon. So why did they choose it? They chose it because it was really quick and easy. The data can be uploaded daily if that's what you wanted to do. And for System 1, the minimal data entry is really minimal. You just need to enter some population figures for System 1. So currently their System 1 screen tells them of the total missing patients, but it doesn't give them the detail that this tool does, i.e. it doesn't give you the number of patients to hit the indicated targets, the achieved amount, or prioritise it in terms of monetary value. It's web-based, so they can use it whenever they are, which is great for remote working. And in the final week, it's really going to be absolutely key when you get to December as well, because it helps to prioritise those and maximise that income to the practice. So they've used it how to influence, how they plan the clinics and their resources. So diabetes is a good example because they've worked out how many diabetic appointments they need to offer each week. The rota planners have factored this into their clinic planning. The recall administrator can then recall on a weekly basis so they can get keeping on top of the numbers. The validation section has drawn their focus to review patients who might not be coded properly, and they're actively working through those who are miscoded to correct them, which has boosted their prevalence and therefore their income. So how did they roll it out? Well, they said they actually started looking at it in April. They run the tool at regular intervals, and then they plan any ad hoc work. But this is how they've been using it, and this is how they're running it at the moment. How easy was it to set up? Once they signed up, it took them 2.5 minutes to import the searches, and then they entered it. So probably about 3 minutes from downloading the searches to seeing the data as I presented earlier. What was the impact? I think the confidence and clarity that it provided, the summary of the points achieved added to their monthly KPIs, knowing the true value of the indicator allowed them to make better informed decisions, and the team have had a better understanding of QOF and also buy-in. Okay, so that's just a quick tour around that and a short case study.
Thanks, Kavita. That's really helpful. Thank you. I'll just start sharing again. Bear with me. Okay, so we're moving on to think about other income streams for a moment now. So we've pulled together this visual to break down the requirements, including cost and how this has changed from last year to this year. So you can see we've included the enhanced access there and both of the elements of the CAP, the capacity and access support and capacity and access improvement payment, along with the IIF indicators. So an example of how to tackle one of the local enhanced services will be covered by Jay, who's going to talk to us from SmartLife in a moment around what they've done in their PCN around diabetes care. We do sometimes get asked for a full list of the local enhanced services, days, quiz, etc. We know these are different in each area. Your ICB and your data quality team should be able to support you with this information. This one that you can see here is an example of how an ICB has laid out all of the LES specs and associated prices. So this is also an example of how commissioning is changing to reflect working at scale. So Lancashire and South Cumbria have a LES intended to increase case finding, use population health and health inequalities, and incorporate interventions that the wider primary care team can deliver around long-term conditions, such as social prescribers, pharmacists, care coordinators, for example. Workforce and commissioning are now being considered at scale by place. So practices and PCNs need to be ready to deliver services at scale and understand the financial impact of doing this. So I'm going to hand over to Jay now, Dr. Jay Verma from SmartLife Health, to talk you through the next section. Thanks, Jay.
Great, thanks. I'll just start. I need to work this out, actually. It's the first time I'm doing this. Does it work? Yeah, perfect.
Yeah, I can see that. Thanks, Jay.
Perfect, no worries. So, hi, my name's Jay Verma. I'm a GP partner based in Northwest London, Hillingdon. Our journey effectively in data analysis started about a decade ago, and it was really down from a poor performing practice, which is the one I'm in a partner with, was going to be shut down by NHS England because it was so run very poorly. And we took on the challenge to try and transform it. But in order to do so, we learned so much more about data as we went along the journey. So the key thing, what we found was that primary care's got numerous challenges. And effectively, you're trying to balance between the funding and trying to manage patient expectation, government expectations, and patient preferences as well. All in the meanwhile, most practices are out there to deliver the best care they possibly can. So the idea was that we were thinking that, even though some patients may have a different perception about why we're delivering enhanced services care, we know working in the practices is that we're trying to deliver the best possible outcome for our patients. The money is not an end product, it's a byproduct of the service we offer. So the question I was really trying to answer was that, is it possible to raise the standard of care and be fairly rewarded without burning out in the process? And that's where it started 10 years ago. So earlier on, we talked about increasing list size. And most practices, whenever I've spoken, we've done some work with hundreds of practices to date. And most practices, when we ask them about growing the list size, they're like, oh, no, we don't want to do that. It's just an additional workload and it will be a nightmare. This is data we've taken from a practice where we thought, okay, how do you grow a list size? And if you can improve the patient experience, does it have a domino effect on your cost of service, or in particular cost per encounter? So imagine you move away from a patient saying, I want a GP appointment, to I have a query, who's the best person that can help me? And just by changing that mindset over, and it's a lot of work, by the way, so it's not as simple as it sounds, but it's worth doing. What we saw over a year when we mapped this out to the the accountant's data, is the cost of service that was being paid out, and then we mapped it against the appointments that were given, i.e. the encounters that were done. So this particular practice was pretty much had a success rate of over 90% of the queries were being dealt with within 12 hours and 100% within 48 hours. And as you can see, it's April 22, so just after or just in the midst of the tail end of COVID. And what you saw is a cost per encounter fall by 62%. So we realized that actually, just because you have more patients does not mean that you become less profitable. And one could argue, well, surely the workload increased. But I'm going to park that one for now at the moment. So we started to answer the question about, okay, well, what is workload? And where is it coming from? Who's doing it? So we did some analysis on capacity and access to try and work out, looking at the payroll data, and then looking at the appointments being offered within the clinical IT system. And let's be honest, no one logs in on a Sunday night for the fun of it on EMIS or System 1 to see, what's going on, but it's going to be work-related activity that's there, and we can capture that work-related activity and for whom as well. And what we found is that 14% of your average list size will contact you in a month. And so you might remember, some of you, about Pareto's principles, where it's an 80-20 rule. Still 6% shy, but you get the gist, that there is a small cohort of patients that are creating a lot of more demand. And then you have to ask yourself, well, what is that demand? So anyway, let's go back to basics. I mean, let's think about, if you're going to collect data, data is only good if it tells you a story. I've taken this, you may have all seen this snapshot of a Lego building blocks, but the data is only good as the way it's collected, prepared, and visualized. And we thought, well, can you use data visualization to evoke change? And so let's park that again to the side for now and think about, this is taken from the King's Fund, about how money is distributed. And you can see that the way the money is coming through, there's several layers. And of course, granted, there's no longer CCGs, and dare I say NHS England is going to be no longer there as well. But you can see how Department of Health and Social Care is going to directly commission a lot of these services to practices. And what does that do for the income in practices? Because the government is going to have the expectation, access and experience are going to be high in the agenda, as we can see from the capacity and access test. And if I just park that through, because I'm conscious of time, to the provider of services, if you were to map out the typical practice cash flows, and let's say it's £100 for easy math's sake, we know that about nearly £20 of that £100 is going to be coming from your enhanced services and QOF. And QOF is going to get reduced further on. It already has, and I'll show you an example in a minute. Whereas I appreciate what Kavita is doing, and it's great work, because I think you still have to do that for the outcomes angle anyhow. But when you're looking at the staffing costs, then can you operationalize it better in order to reduce your cost of service? And if you can do that better, then of course, as Stacey had mentioned earlier on, your profits will also drive up. So if I just quickly go through the QOF, how it's calculated, you might be familiar with the adjustment disease prevalence factor. And so it does make sense to improve prevalence, probably not so much now than it did, say, 5-8 years ago when we used to do some of this work. And that's only because although the pound per point has gone up, the CPI ratio has also gone up. And the problem with that is then that causes a proportionate level down of your income you're receiving. So let's use an example for asthma, for example. So currently, if you hit asthma, you probably get about just shy of £4,000 by the end of fiscal year 29. But if you improve your prevalence even by 1%, it will go up by just over £700. But then one would ask, is this work worth doing? And I think it is, because from the clinical angle about it. And if I give you this data, that from this practice, these group of practices started back in 2015, and they mapped over the 5 years how their prevalence improved to overtake that of NHS England's prevalence. And I have another example to share with you. So if you map out what your QOF achievement is and what your QOF maximum should be, I wonder if anyone could hazard a guess why there's a gap in the left graph between this practice. So they've got the QOF maximum, but the QOF achievement isn't there. So what could be the reason for this, do you think? And this is, of course, all data anyway, so ignore the y-axis for now. I feel like I'm talking at you, and I was kind of hoping people would shout back questions and answers, but fine. Okay, so it's usually down to operational or clinical inefficiencies, really. And so you have to ask yourself that, am I as efficient as I should be? And sometimes you might say, I can be. This is all I can hire, and this is therefore what I can deliver. Just to prevalence is very it's so controversial. This was some work we did with Redbridge CCG back in 2019. And what we found is that prevalence for osteoporosis was far above even the NHS England average. at 3.2%, if you believe it or not. So if you imagine a neck or femur fracture could cost somewhere between £25,000 to treat, and the mortality rate is about 30% in the first year, you're thinking, well, if you do the prevalence work, as Kavita has mentioned before, then surely it's worth it. And so, of course, there is reason to improve prevalence from not only from a clinical angle, but also for a financial angle, but for the wider economy as well. Sorry, Stacey, am I doing okay with time? I'm afraid I drifted away from the time. So
about 2 minutes, Jay, I think, if that's
okay,
all right.
cool. Okay, I will rush across. What we decided to do was try to map these data out and put them into a portal. Nothing fancy, just a fancy spreadsheet with illustrating data. And what we really wanted to do was try and evoke change. Good thing about medics are they're very competitive. So use that and use that among your own practices. And there's always going to be early adopters, forward-thinking practices within a group in a PCN. And as long as they're leading the charge, I think everyone else should also follow suit. So we did this work. We work with this PCN on a monthly basis to try and inform the care. And you're probably thinking, well, where's the data? Here you are. There's the data. In 2022, they're right at the bottom. March 23, they improved, started using the tool, and they've shot up for the pre-diabetes annual review checks. They did the same for 9 key care processes, bottom of the table. And then after using a tool, they increase. I'm not saying it's directly relevant to SmartLife, that's what's caused it. All that's changed is that data visualization, the story it tells. And as a result of that, they also did the same for the 3 treatment targets as well. And now you can see on the far right-hand side, we're only in July 2025, and they're already above the target. So we've brought that fiscal year end down to now within the first 6 months. So now practices have breathing room come winter, autumn and winter time to manage their demand surges they have. And the feedback has been positive from it all, just from the data visualization angle. So I hurried that along. I hope that was okay, Stacey, on that time-wise.
Yeah, no, perfect, absolutely fine. So if anybody's got any questions for Jay, all of our speakers that are hanging around until the end today for Q&A, but if you want to type anything in the chat, Kavita, thank you. I can see you've been answering some of yours as you go along. So yeah, Jay, I'm sure you can do the same. But yeah, that's great. Thank you so much.
All right, thanks.
I'll just start sharing again. Okay, so thinking about some PCN specific things now and the way we can sort of collaborate across teams and create opportunities around shared service delivery, pooling of resources, and joint bidding for local authority contracts and population health management initiatives can all be done sort of at scale. And then in terms of the network DES delivery, thinking about your additional roles, your social prescribing, care coordination, structured medication reviews, and your CVD prevention. We've pulled some case studies, some best practice case studies together as well, which will be in the toolkit that Claire mentioned at the beginning of the session. And you can use the fit test example in that as a step-by-step approach to setting services with efficiencies across PCNs. So on that note, the IIF indicators have been reduced over recent years. They are now down to just these 2. So that is the percentage of patients on the Learning Disability Register who have received an annual learning disability health check and have a health action plan. And the cancer indicator, the proportion of patients who have had a lower GI urgent suspected cancer referral, and have an accompanied fit test result as well. So those are the 2 indicators. So just another one here, some key action points for income maximisation around learning disability health checks. So you can improve register accuracy, implement systematic recall processes, ensure your action plan completion post-check, and target your achievement gap, and that can equal a £585,000 potential. And then the next one that you can see there is the fit testing in cancer referrals. So if you standardise your fit testing protocols and improve your clinical system accordingly, ensuring that 21-day recording compliance and target that achievement gap. So there are platforms such as Ardens and See the Signs. They have built-in tools to help you identify IIF funding opportunities as well. On the capacity and access improvement payment, an element of the DES, there are now 2 domains for the capacity and access improvement payment element. So that's modern general practice access, so telephony, simpler online requests and faster care navigation. And secondly, the risk stratification in accordance with need, including those that would benefit most from continuity of care. So we know everyone will be ticking boxes to say they've got QI plans and delivering continuity of care, but I think they pose the question of what does that actually look like in practice? How do we demonstrate we've used risk stratification intelligence? There is a recent article in Pulse PCN in the last couple of weeks talking about the amount of funding that wasn't granted for the CAPE payment. Modern general practice has formed the bulk of what we do at Redmoor for the last 3 to 5 years, and we've supported a number of PCNs to achieve full CAPE achievement. So do drop us a line after the session as well if you're interested in one of these areas and you're in one of those areas that you can see and you were affected last year by not getting the full payment. So thinking about other additional revenue streams rather than the typical ones that we've talked about, other things that you can do to increase your revenue. Have you got capacity to support trainees? Can this be supported through the PCN? Can the new Rs GPs backfill into practices to release training capacity from experienced GPs to then to supervise trainees? So in terms of GP registrar training income, a single registrar practice can earn £10,382 annually. In terms of additional benefits, that will give you an enhanced reputation, recruitment appeal, access to latest clinical education resources, reduced locum costs through registrar clinical contribution, continuing professional development opportunities for your existing staff. Thinking about medical student training, as well, that can have equal sort of benefits in terms of finances. To have a premises review, so maximise your notional rents, seek advice on lease arrangements and try to optimise space usage. We've at Redmoor been working on a smart building project to optimise space usage and building energy management systems as well. Jay, you've got a hand up.
Yeah, I was just going to say also it gives you 120 clinical appointments per week. So
yeah, so really freeing up, sort of helping with capacity there as well, absolutely. Research opportunities as well. So in terms of research for the practice, by supporting research culture, you can encourage a research-aware culture by training staff, providing resources for patients and enabling doctors to participate in research. Partner with academic institutions, research organisations and industry sponsors to conduct high quality clinical trials and really make opportunities to collaborate. Implement infrastructure, so ensure you've got secure, confident storage for research documents. And for the GP, working with patients to talk to patients about interest in participating in studies, help them to access any clinical trials that may be appropriate for them and recruit them into studies as well. Dispensing practice as well, mentioned at the bottom there as well. So make sure that you're a member of Dispex as well, an organisation that will really help you make sure that you're optimising your all of your opportunities in terms of dispensing practices. Just a couple of other things here that we've pulled together around organisations that can conduct free premises health checks. So there's BW Healthcare Surveyors at the top there. A couple of other organisations around maximising dispensing practice opportunities. So we'll include these in the resources so you can have a look at those where it may be helpful for you. In terms of operational efficiencies to protect your income, Group consultations across the PCN or by video with your additional roles teams. Social prescribers can do some of the health and wellbeing support and then bring on clinicians for more specific things. Recruitment, rather than each practice considering their own workforce, do you each need a nurse with diabetes skills, or could you have a specialist diabetes nurse providing a PCN service? Does the nurse need to ask the same preamble questions in every 20-minute appointment? Could this be done differently and save time and appointments? Think about a one-stop shop appointment with healthcare assistants to do all of the workup and all of that holistic care that needs to be done. So the clinician then just looks at results, advises on the care plan. Think about what online tools you use to capture pre-clinic data from the patient as well, so that your time is better spent in the appointment rather than asking questions. The clinician's validating the answer and then working up the plan. So mentioned management of locum costs on the previous slide. So collaborate and recruit and cover in this way. So you can use organisations like Valor, the National Association of Sessional GPs, or there are platforms like My Locum Manager to help fill gaps and keep a consistent workforce in your areas. So other things that to consider there. Consider the impact of poor data quality. I know this was one of the things that Claire mentioned around the feedback that we'd had from the survey and making sure that coding is correct. So we'll all know the phrase rubbish in equals rubbish out. We know GP consultations don't necessarily lend themselves to nicely structured data entry templates. A lot of QOF work is nurse-led. Nurses do seem much more comfortable with those templated healthcare approaches, case finding searches to increase prevalence. In terms of coding in the clinical system, data entry templates do need to be up to date. Business rules change and the template needs updated. So make sure that you're archiving your old one and you've told your nurses that they need to use the new one. I think Tim from Suvera will cover a little bit around effective management of long-term condition recall and their calculator that they have as well can look at prevalence increase in impact. So we'll have a look at that just now. Tim, you should be able to share your screen. Are you able to take over?
That should be absolutely great. So hopefully
everyone.
Hopefully you can see that.
Yeah, that's sharing. Thanks, Tim.
Real, thanks so much, Stacey, and thanks to the other kind of speakers, I think, for sort of setting the scene really nicely. So I'm Tim, I'm a GP partner by background. I work just outside of Basingstoke. I'm also medical director at Suvera. So I think the bits that I really wanted to think about was, I guess, kind of building on what we've heard. So thinking a little bit about the GP contract today. So thinking about what's in it, what do we need to do to kind of maximise our revenue from it, but then also start to take us a little bit looking further forward as well. So thinking about kind of what's coming. So there's Wes on the phone to me telling me to open up from the 1st of October, but things that we really need to be thinking about as we move forwards. So if we think about the today problem, which we've heard a bit about already, so we know that there's a little bit more funding coming through in places, which is good. We know that QOF is particularly much more targeted. So that real heavy focus on CVD, good in some senses, because I think it allows us to focus our clinical workforce much more in a much more kind of a sort of measured manner. The challenge is that this is all about outcomes. This is all about treating people and getting people to target, which can sometimes be trickier than it looks from the outset. We've heard as well around the additional roles. So again, the value has gone up slightly. We've got more options. So things like additional roles GPs, which is fantastic. So again, always worth looking at, are you maximising what you're doing with your additional roles today? There is this increasing challenge around access. So the whole country is being moved whole scale towards digital, which is a good and a bad thing. Us at Suvera, we tend to think it's a good thing, and I'll talk to you about why that could be. But again, just thinking about how you want to prepare for that kind of always open approach from October 1st. Again, maybe a new contract coming in the future as well. We saw payments for A&G, so there's definitely this move about moving more activity into the community. Again, I think on the Les slide I saw earlier on, I think it was ridiculous, less than £1, I think, for an A&G on the one that you said from Lancashire, which, goodness me. But I think there's lots of opportunity if we start to think correctly about how we can work this. And then lastly, really thinking about population health and thinking about actually how we're managing the population that we're looking after in the most effective way across not just our front door, but everyone else's as well. So if I put my partner hat on, I think these are the three things that probably worry me most at the moment. Finances are super tight. They always have been in general practice, but I think we're having to work harder than ever to make it all stack up. Again, we see it in our workload. They're super stressed. They've got lots on their plate, and understandably, that's taking an impact as well. And then lastly, there's this concern around clinical risk. And really, it's about people having access. So one of the great challenges with digital models is, are we ensuring that we're actually seeking out the most vulnerable, those people who potentially might be at greatest risk, because often they're the ones that aren't digitally engaged. We see that in the population. So one of the main reasons that Suvera exists is to try and support this challenge of the aging population. We know that long-term condition growth is coming. We know that the majority of our appointments in general practice relate to long-term conditions. And certainly when you look at the data, actually lots of time is spent supporting people with long-term conditions. So this is a problem that isn't going away. So I would encourage all of you just to think about what your current process is for managing long-term conditions. And really, when I think about your sort of team's time, you really have to boil it down into how much does it cost? Because every time your team member is doing something, that is a cost to you as someone that's either running a PCN or running a practice. So we see lots of good models. And again, we could have heard from ones today. All of us will know things like Ardens. All of us, I'm sure, are using things like AccuX to kind of bombard patients with kind of messages. But again, it's quite a lot of work. And so unless you've got a structure where you're really thinking about the whole process, it can sometimes be really unclear about who's doing what and are you doing it in the most efficient way. In the work that we do in Suvera, we have some software which can automatically pull all the clinical data in and make sure people are being sort of addressed. We've got some digital bits that we use, our own patient web app. So rather than lots of messages, they're just getting an entry point into a single space. And then we've also got a clinical team as well to be able to kind of manage if you're struggling from a capacity point of view. This is the kind of high-level pathway that we use in Suvera. Again, one of the ones I would just encourage you, if you haven't done this piece of work already, is it's worth mapping out how do your patients end up in your long-term condition appointments. So how are they getting there? Map through every single step, because every time it lands with somebody, it's going to have a cost to you as a business. Also worth thinking about from a resilience point of view as well. You don't want to be in the position where the person who does recall goes off on long-term sick, and then you're not quite sure whether you were doing it by month of birth or by greatest risk. So worth just mapping that process and being really, really clear about what process you take within your practice or PCM. But I'd also encourage you to think a bit around how you care for people with multiple conditions, because the reality is the majority of people don't just have one condition. They often have multiple. And again, you can start to think about how you can be more efficient in approaching the way that you manage those patients. So if we take an example patient who has hypertension, diabetes and cholesterol, it's going to be far quicker and far more effective and far more cost saving if we can deal with that patient in one appointment. We're going to need to extend it because there's a lot to do. But again, if we use a single appointment, we can get them completely ready for that appointment, and then we can manage all of it in one go. Again, one of the things I think a lot about in my practice and certainly across the work we do in Suvera is how much it physically costs today to put someone in a room for a period of time. And again, worth looking at all your additional roles, who you have working with you, to think about who is the right person to do that job. Have you been absolutely certain that you're using the right staff member at the right price point to deliver the service that needs to be done? Again, at Suvera, one of the things that we do is we can organise all of this for sort of teams that we support. Lastly, I just wanted to focus a little bit on the tomorrow problem, which is the growing piece around neighbourhood healthcare. So lots of it talks around population health, and at a very high level, really what we mean by that is understanding the interactions that your population have across all of different parts of healthcare and how best to approach it. On the left there, you'll see something called PNG. So this is the Johns Hopkins risk stratification scoring system. Again, worth having a look, because capacity and access payments this year in particular for the DES encourage you to look at population health software and use those and deploy those in practice. Something like the Johns Hopkins actually looks at people according to their patient need group and overall risk. The reason systems like this, and I used to work in an ICB, and this was all they kind of spoke about, is because we know that patients that tend towards the kind of the 9 or 10 groups there, the people with more chronic or complex conditions, they tend to cost the system more. So when you've got a health system that's financially struggling, we will always go to the point where there's lots of cost in the system. So there will be an ask of us to think about how we support those patients who are potentially turning up to A&E with a long-term condition that hasn't been managed. But importantly, this isn't just general practice's problem to solve. We see the beginning conversations in our area around neighbourhood healthcare. The first wave of sites was released last week. But one of the things that I would encourage you to do if you're not having conversations in your PCN already is start to find where those conversations are, start to get into the conversation, because there may be opportunities again to deal with that cohort of patients in a slightly different way. The last thing I wanted to focus on was just thinking about how you deal with digital engagement. So digital tools are here to stay. Generally, they're pretty good. So if you're sending out accuracies today, I think the last data that was from about 2 years ago, about 66% of people respond to a florey. So not bad. So you can send lots of messages out and people will respond. But I'd encourage you just to think around the patients that don't respond. So one of the things that we do at Suvera is we think really carefully around who's not engaging with our service. So this is an example from a team up in Manchester we're working with, and actually we're able to plot where people aren't engaging with us. We're able to go down to the actual postcode level and look at where they're based and organise kind of outreach with the community with them. It's also really valuable when you can start to think about the type of people that you're trying to engage with. For the population here, they were predominantly sub-Saharan African. So actually one of the conversations we had was around working directly with local church organisations to try and do outreach events. Again, it's not uncommon for ICBs to kind of fund novel ideas like this if you can go to them and explain what the problem is and how you want to solve it moving forwards. The last things from us, one of the bits that we're kind of team are working on, we have our kind of recall software, which is inbuilt into our virtual clinic for customers that we work with. We are looking at kind of releasing this for the start of next QOF year. This does have IM1 integration, so it's completely live. So it automatically pulls data in and it automatically puts data out, and it should be pretty helpful. But if you're interested in learning more, we'd love to kind of talk to you about it. And yeah, thank you for listening.
Thanks, Tim. That's really helpful. I'll just go back to my slides. Okay, so yeah, I think we have mentioned CQRS earlier in the session. Most of you do probably know about it. For anybody that's new to the role or are not familiar, the cycle of accepting new services, updating activity, ensuring extracts through GPES run smoothly, all another essential element of income maximisation. Many areas are supported by CSUs or data quality teams, but for practices and PCNs still need to ensure collections are done accurately and reflect activity, and that any manual uploads are done in a timely manner. So understanding the delay between uploading activity and payment is also important, especially for cash flow and around the time of seasonal vaccines as well. So sign up on CQRS, accept any service offer at the start of the year, and worry about the delivery later in the year. Check your reports each month to see that activity is being uploaded. Some areas have support, others you might use PCIT or Ardence for the reports to help gather data from the clinical system and update CQRS that way. So just a few tips here around income opportunities. So there's a number of crossovers here. So I think you can see those. The point that we're trying to make on this slide is that there are a number of overlaps in the work that we do. So think about sort of case finding, how we can work to reduce visits to the practice by getting people with multiple morbidities into one appointment with those sort of one-stop shops that we've mentioned. Use of online forms and questionnaires to capture data before the clinic, ensuring that it's all coded. Thinking about your recall strategy, so consider your approach, whether it be month of birth, oldest first, your financial big hitters or your multi-morbidity patients, and group consultations, so one-to-many can offer real-time efficiencies as well. Acknowledging personalised care planning needs, risk stratification for the wider system for continuity of care. We are also offering an income maximisation managed service at Redmoor Health, where we can help pull some of what we've talked about today together. help you think about where the gaps are in your data and your targets, help you with running some of the searches that we've talked about, and getting your recalls to engage the right patients. So do get in touch with us if you are interested in knowing a little bit more about that after the session as well. Okay, so we'll move on. We are coming towards the end of the session. So it's over to you guys really in thinking of what's next. So just some tips about using data effectively. So leverage the search tools that are out there and your clinical systems to identify the gaps and opportunities. So for example, your missed QOF indicators, your long-term condition reviews, flu and vaccination update, enhanced services. Use your data proactively to prioritise patient recalls and optimise your coding. Review appointments and capacity. So assess your clinic templates regularly. Are slots aligned with your current demand? Identify where underutilisation or any bottlenecks are occurring. Consider your skill mix, use of your additional role staff to increase that capacity. Try to align appointment types with income generating activities where you're appropriate. Team engagement and motivation. So share performance data with the whole practice team to create ownership. Celebrate progress towards targets as well to maintain motivation. Ensure you have clear roles and responsibilities for income related activities, and provide training and support to build confidence in achieving goals. Align your clinical priorities with financial return. So patient care does remain at the centre and financial sustainability supports this. So balance your QOF, IIF, your LES, DES requirements with local population health needs. Prioritise the activities that improve outcomes and contribute to financial resilience. Try to avoid duplication and focus on interventions with the greatest impact. And having a support network. So collaborate with other practices within the PCN to share resources. Maybe each practice manager could take charge of a particular element and then share the learnings, come together and share that. That type of peer support can really reduce workload and encourage innovation. And benchmark against others to identify opportunities for improvement. That's just a reminder, as Claire mentioned at the very start as well, of the support offer that we've got. So if you don't have full access to the hub at the moment, and you would find the D&T support helpful, or access to the toolkits, to get in touch. And finally, as Claire mentioned at the beginning as well, we would be really grateful if you wouldn't mind taking just a couple of minutes to fill in our feedback form for today's session. Really helpful to us as we're building these sessions to get that feedback so that we can work to improve these for everybody. You will, by filling it in, go into a draw as well, so you can win a £25 Amazon voucher for filling that in. So you can use the QR code on the screen to do that. And that is the end of the session, just about on time. I'd like to thank Kavita, Jay and Tim for joining us today and giving those really helpful insights into what's out there and those sort of real life case studies. Thank you, everybody.